Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Thank you, Brian, and thank you everyone for having me again for part 2 of this. So as a reminder, I do not have any conflicts of interest or relationships to disclose. And for those people who are joining today that weren't here last week, as a reminder, this is the updated 2020 HIVMA Primary Care Guidance that we are reviewing that was released in November of this year. Last week, we talked about optimizing care engagement, medication adherence, and viral suppression, and the initial evaluation and immediate follow-up for people with HIV. And today, we're talking about routine healthcare maintenance and metabolic and other non-communicable morbidities. As a refresher, the way we'll do this is that I've sort of picked and chosen with some help from Brian about what topics we're going to talk about. I will give you some reminders about some things that we should be doing routinely, and then have audience response polling about some areas in which there may be some practice variation. And again, like last week, I really encourage people to reflect on how these new guidance may affect or change your practice. So without any further ado, this is section 3 and about routine healthcare maintenance. So this is basically a distilled version of their table 5, which is routine healthcare maintenance for people with HIV. It's another 2-page behemoth of a table. And the way that I've tried to sort of parse this down is into things that we do routinely, things that we do only in certain scenarios, and areas for discussion, sort of similar to how we discussed last week. Now, although the reminders I'm going to be giving are about HIV RNA levels, chemistry panels, and CBCs, and we will be discussing CD4 cell counts and urinalysis, I did just quickly want to sort of review some of these things, that routinely we should be doing mental health screens, substance use screens, and checking blood pressure and weight checks, which are occurring when people come in, that we should be screening routinely for syphilis, gonorrhea, chlamydia, and trichomonas. And for trichomonas, that should be annual screening for persons having receptive vaginal sex. And with viral hepatitis screening, I think, we're getting a hepatitis A and hepatitis B screening upon initiation. But then for men having sex with men, transgender women, or injecting drugs, that hep C should be checked annually. Then moving over to the middle column, some reminders. This is mostly about sort of cancer screening for certain individuals. And then TB testing, I wanted to give a little bit of a reminder that if quantiferon or an IGRA was checked with someone who had a CD4 count less than 200, that it is recommended to repeat that when somebody has immune reconstitution to a CD4 count greater than 200. So what I do in my sort of healthcare maintenance table is that I will write the CD4 cell count, or at least I'm trying to do this as part of my practice, is that based on what the quantiferon result is, I will say what the CD4 count was at the time of that test, and we'll say repeat once CD4 count greater than 200, or just leave it at that if their CD4 count was greater than that. And then lastly, the areas for discussion, as I mentioned, we will discuss CD4 cell count and UA in a little bit. We will also mention lipid profiles, A1Cs, and we are avoiding, or at least I am avoiding for today, talking about anal cancer screening and prostate cancer screening, as that is actually areas of many hours of discussion. So we'll leave those aside in the interest of time. So for these reminders, the first thing that I wanted to refresh people about is about the frequency with which we should be getting an HIV RNA level or a viral load. And the reason why I'm bringing this up as a refresher is working with trainees, I noticed that there's a lot of practice variation, and so I thought that we could take this time to review the guidelines. That after ART start, an HIV RNA should be rechecked after 2 to 4 weeks, but no later than 8 weeks, and then every 4 to 8 weeks until suppression is achieved. That thereafter, viral load should be monitored every 3 to 4 months. However, viral load may be prolonged to every 6 months for, quote, adherent patients whose viral load has been suppressed for more than 2 years and whose clinical and immunologic status is stable. I recognize that there may be a little bit of variation with that, but I really do like to see people and get to know people for a fair amount of time before I start opening the interval up to 6 months. And then there's a very small subset of people, very, very small, in whom I am doing every 12-month screening. But again, I just wanted to sort of remind people that this is what the guidelines recommend, both the HIVMA guidelines and the DHHS guidelines for when to feel comfortable spacing somebody out to every 6 month checking. And then, as a caveat, that a viral load should be monitored more frequently after ART start or switch, And they say here that it should be preferably within 2 to 4 weeks with repeat testing every 4 to 8 weeks until viral load becomes undetectable. My practice in the outpatient setting is that I am checking somebody after 4 weeks of a ART start or switch. And then if they remain detectable, then I'm having them come back on a Q4 week frequency as opposed to the Q8 week frequency. So that's me. The other thing that I think is interesting is the CBC and chemistry panel. So the HIVMA Primary Care Guidance from November suggests that a complete blood count and chemistry panels should be monitored on a regular basis as needed to assess medication toxicity and to monitor potential or existing comorbid conditions. These reminders are also areas in which there is some variation. And the reason why I wanted to bring this up is that the DHHS guidelines actually recommend checking a chemistry panel and a CBC at different frequencies than the HIVMA guidance does. And I think one thing I appreciate about this guidance is that they say it should be monitored on a regular basis as needed. So that's really up to you. I think some things that they suggest are with regards to if people are on either if they have comorbid conditions, such as CKD or hepatitis, that may increase someone's risk for kidney issues, or if they are on tenofovir. And again, there's a lot of practice variation about whether they're on tenofovir disoproxil fumarate or tenofovir alafenamide. And what I do is I tend to now, after this guidance, which gives me a little bit of leeway, has made it so that I check a CBC maybe once a year, because unless there's an abnormality, because at least for a lot of young patients, I don't think I need to be checking a CBC every 6 months. And then a chemistry panel, I am still checking on a Q6 month basis, because with that, I'm curious about the creatinine and I'm curious about LFTs, especially since we are taking care of patients who may be at risk for hepatitis C or other hepatitides as well. And so that's where I stand on that. But I think this gives you a little bit of space to sort of really do what you think works well for both you and your patients. So moving on from the reminders to our audience response polling. Regarding CD4 cell count, in a person with HIV with a CD4 cell count greater than 500, how often do you check the CD4 cell count? Is it every year, every 2 years, every 5 years, or never or almost never? And again, this is someone with a T cell count greater than 500. How often are you checking a CD4 cell count? And this is not to say, what do the guidelines say? This is just, what are you doing? Because there is a lot of practice variation with this. Okay, great. So we have some 78% of individuals say every year, about 4% of individuals say every 2 years, nobody said every 5 years, and 17% said never or almost never. And I think this is up for discussion. So I'd like to sort of review what the primary care guidance says, and this is actually the same as what the DHHS says, that CD4 cell counts should generally be monitored every 3 to 6 months for the first 2 years, or if the virus is not suppressed. For patients on suppressive ART regimens with a CD4 cell count 300 to 500, a cell count can be monitored every 12 months unless there are changes in the patient's clinical or virologic status. If the CD4 cell count rises above 500, however, then CD4 monitoring is optional. And so I just wanted to review that because optional doesn't really give us a lot of guidance. Optional is sort of really opens up the world. And so I think it is interesting. I know some people who truly never check after someone's CD4 cell count is greater than 500, especially in someone whose CD4 cell count is greater than 1,000. I know some people who check every 5 years if their CD4 cell count is greater than 500. I am a lab-happy individual, and I always want to know what's going on. So I find that I'm checking every 2 years, but I don't actually think that that's necessary, and that might be truly unnecessary. So I'm thinking about this more. I want to encourage people to talk about this more and think about it, but I did think that it would be interesting to share the fact that it's not really needed anymore if your CD4 count is greater than 500. And I think a big barrier to changing this practice is actually patients themselves, because a lot of patients really focus on their T cell count and they want to know. And I've had so many people say, why didn't you get a CD4 cell count? Especially if I'm putting in labs for someone else's patient. And so I think it's just important to do some education about that. And then for some people, if they want it, I get a CD4 cell count, even if it's unnecessary, because it's really important to them. So it really just depends on the patient, and just wanted to share that. So I'm sure we will talk about and ask what you all are doing after, but for now, I wanted to move on to the next audience response question, which is about your practices surrounding urinalysis. So in which asymptomatic persons with HIV do you check a UA? Do you check in every person with HIV every 6 months? Do you check in every person with HIV every 12 months? Do you check in people with HIV taking TDF every 12 months? Or do you check anybody taking any tenofovir-containing regimen every 12 months? Again, there's no right answer. Just sort of what do you do? Ooh, so fun. This is great. There's a really good spread here. So 10% of people check every 6 months regardless in everybody. 48% of people, so nearly half, check once a year. 14% of people only check once yearly if the patient's on TDF, and about 30% of people check once yearly and only in people taking any tenofovir-containing regimen, whether TDF or TAF. And so what the recommendations actually say, these are, again, the HIVMA recommendation says urinalysis should be monitored annually among those at risk for kidney disease. Now, some older recommendations from what I have seen recommended UA every 6 months. Then what I saw most recently in the DHHS guidelines say that if you are on a TDF containing regimen, that you should continue checking every 6 months. And then if everybody else should be every 12 months. And so I think I can't say that I did anything with regularity when it came to urinalysis. I don't know about other people's experience, but sometimes it's hard to get people to just pee, and we'll say, let's get labs. And then oftentimes I order a UA and a UA hasn't been done, whether it's occurring here or in the laboratory. And I let that slide. I think in people who are on TDF, I will continue to check Q6 months, especially in the state of Washington. I know that we are having to use TDF more so now due to our state formulary. And so I've sort of now gone back to checking TDF on a Q6 month frequency. And then if someone's not on TDF or on TAF, I will be checking every 12 months. What will I do for someone who's on a tenofovir sparing regimen? I think based on these recommendations and based on what the DHHS says, I will default to monitoring annually, but also recognize that I may not be as strict about that. And again, I sometimes forget about the urinalysis, even though it is important for some. So that is the end of section 3. And for section 4, there are only 4 recommendations, 77 through 80. And so their first reminder is about lipid levels. And I just wanted to put this out there that they suggest that lipid levels should be obtained prior to and within 1 to 3 months after you're starting ART. There's a long ... because they talk about, there's a lot that goes into this recommendation. And they recommend that in people who have abnormal lipid levels, that you should check yearly, but then otherwise they don't give much guidance on the frequency after that initial lipid panel. So what I do is check a lipid panel when somebody comes in, especially since I know that ART can potentially affect that. And so I check at the get-go. And then there isn't, like I said, there isn't much guidance. I'd like to read to you what they specifically say. They actually say for frequency of follow-up in somebody with a normal lipid level, that they should use the lipid guidelines. And actually, if you go to those lipid guidelines, the recommendations aren't clear there either. And so the HIVMA Primary Care Guidance in one table says that if it's normal, you can open it up to every 5 years, but that's only located in one place in the guidance in a table form and isn't in the paragraph or the sort of evidence summary section. So this is really something that there isn't much guidance. I think people can do what feels most comfortable for them. Interestingly, the DHHS guidelines say to check once yearly regardless. And so what I find myself doing is that if someone's less than 40, I am checking once every 5 years if it's normal. And then once somebody hits 40, magical number for me, I don't know why, I start checking once yearly. And again, that's just because people are perhaps more at increased risk beyond that age, and especially people with HIV, as we know that the HIV itself can sort of increase cardiovascular risk. So that's what I do. There's not much great guidance about that. Another interesting sort of point and a reminder I wanted to sort of show, but again, these are all sort of full of practice variation, is the random or fasting blood glucose or hemoglobin A1C for diabetes monitoring. So they recommend that a random or fasting blood glucose and hemoglobin A1C be obtained prior to starting ART. So I am using an A1C when somebody sort of establishes care. And then the recommendation thereafter is a little bit fuzzy. It actually says that once you're on ART, to then only screen for diabetes with a random or fasting blood glucose level on a yearly basis. Interestingly, the DHHS guidelines also say to do that once yearly. And that's because there are some data that suggest that having HIV can spuriously decrease your A1C level. I found in some places it said 12%, not 12 percentage points, but by 12%. And then that there's a discrepancy between the A1C and the blood glucose, where the sort of blood glucose seems spurious, like it would be essentially like the blood glucose was about 29 points lower. Now that's a lot from older data in really retrospective cohort analyses and in small studies, like of people of like 100 people with HIV. There is more recent data with 1,000 people with HIV where they found that the A1C differential and blood glucose differential was negligible. And so basically all this to say is that the more you look into this, perhaps the more confused you may get. I just want to reiterate that there can be an abnormality, or not an abnormality, but a false lowering of A1C in people with HIV. But that in general, an A1C is fine for monitoring. And I think we should always be looking at the blood glucose as just as a comparator, because we're getting those chemistry panels so frequently anyway. And like we should for any patient sort of look at that discrepancy to make sure we're not missing diabetes. I don't think that we need to sort of do anything much differently. This could truly be a talk on its own because there is a fair amount of literature about this and people have studied this. But I just wanted to sort of highlight that that's a point of contention, highlight that we should be screening for diabetes once yearly, and sort of leave it up to you as to how you want to do that. So for our last audience poll, they talk about DEXA screening in the guidelines. And so I want to know, in which people with HIV do you order a screening DEXA? In asymptomatic men greater than 50 years, in asymptomatic men greater than 60 years of age, in asymptomatic men who are greater than 50 and have a FRAX score greater than 10%, or that you do not routinely order a screening DEXA. Great. So 33% of people said they get it in people greater than 50, 14% in people greater than 60, 10% of people are using the FRAX calculator, and with the FRAX score, you can either put in DEXA information or not, and so here it is without the DEXA information. And then 43% do not routinely order a screening DEXA, and this is definitely an area for discussion. So technically, recommendation number 79 is that a DEXA screen for osteoporosis should be performed in postmenopausal women and men aged greater than 50 years. There's not a whole lot of guidance about how frequently to be checking that, and they say that this should be done. Now, there is some data to suggest that people with HIV have higher rates of osteoporosis, and I think what's also interesting is that HIV itself directly can infect osteoclastic precursors, and actually HIV itself, this is sort of new information from 2019, and so as a result, HIV may be causing more bone resorption at the osteoclastic level. So that's probably some of the background behind it, but I think that there's a lot of practice variation here. I order a DEXA screen in somebody greater than 50 after I've hit every other healthcare maintenance thing is sort of how I go about it. Or if there's someone who really wants to do all their healthcare maintenance, I'm getting it. But it's something that I can't say that I do with great regularity, but I do think about it in people greater than 50. I know there is a lot of difference in sort of practice. So again, just one page of conclusions that the viral load can be spaced out to every 6 months in a specific subset of individuals, for which there is pretty clear criteria. All of these things, practices regarding cell count, CBC, chemistry panels, lipid levels, diabetes screening, and DEXA screening are variable. And how will your practice change after doing this? Or will your practice not change based on sort of reviewing the data or like reviewing the guidelines? And so I am done and would love to hear what people think and people do, especially with some of these sort of contentious recommendations.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.